Okay, Dr. Elijah, we are ready to start.
Okay, do you want me to start?
Yes, please.
Or you'll do a bit an initial introduction, then I go ahead.
Sure. Good evening, everyone. Thank you for joining. My name is Lvdot Diameter. I'm the product manager for cardiac ultrasound from GE Healthcare. Thank you for joining this first of many sessions to come for the ACE courses, the advanced courses in echocardiography. This is an educational program for the latest and the advanced developments when it comes to echo. Bringing you the expertise a bit a level higher, so that you can actually so we empower people to implement these latest advanced tools. The program this year is actually, or this time, is under the umbrella and the collaboration of PASCAR, Pan-African Society of Cardiologists, headed by Professor Elijah Ogola, who is joining us here to welcome you, and so that we can start this first session. So, Professor Elijah.
Yeah, thank you very much. And thanks for reminding me. As I told you, I'm in a meeting somewhere in Europe, so I almost forgot. It is my pleasure on behalf of the Pan-African Society of Cardiology, PASCAR, to welcome you all to this first session of the ECHO training. I wish to particularly thank GE for having made this overture to us and partnering with us in, helping us to fulfill our mission as PASCAR, which is to improve cardiovascular care. And an important plank of improving cardiovascular care is, of course, medical education, increasing the capacity of the practitioners to carry out the necessary investigations and treatment. So I trust that the whole series will meet its objectives, that it will be a useful educational experience, and that going forward we'll continue to partner with GE in many more projects in the future, and that hopefully after this series we'll probably make this an annual event so that we keep on repeating it. So I don't want to spend too much time talking. Let's get to the meat of the thing, which is echocardiography. So wherever you are, whether it is morning, afternoon, like where I am, or evening, I thank you very much for joining, and I wish you the best. Thank you.
Great. Thank you very much, Professor Elijah, and thanks everyone for joining. So again, today we'll have the first of the series of the ACE courses, or the advanced courses in echo. Today, as you know, we will cover the value echocardiography, some of the basic principles, and the latest new technologies, AI tools that are being implemented into the routine echo. As you can see, as you may have registered, all the sessions will be on Thursdays starting this week, and it will be in every Thursday from here on for the next 5 weeks, with the next courses, for the echo navigators, and then followed by for the echo experts, in depth and into strain, and then again for the echo with dedicated tool for interventional and structural heart procedures. So there will all be the same time. And again, if you haven't registered for the other sessions, you can go through the link again and register for the next following sessions. So, and now today we have with us our colleague Joel, who will be going through the first session, which is the ACE value. So Joel.
Yeah, thank you, Lvdot. Thank you, Dr. Elijah, and thank you everyone for attending our first session related to our AI tools on the value segment. And before any further delay, I'll be sharing my screen. Just need the confirmation that everyone can see my presentation.
Okay.
Yes, we can see it.
All right, thank you. So as I mentioned, today we're gonna go through all our advanced AI tools available on the value segment. And before moving on about the importance of every single tool that we have, we're gonna highlight the importance of our raw data. And due to our raw data, we can do everything. We can do everything on the offline mode. And even later on, we're gonna see with the advanced course that even we can do the 4D navigation and even the 4D valve and chamber quantification. So during this course, we're gonna go through what is the raw data, what is the importance of the raw data on the routine echo, the anatomical mode while using the raw data, how we can optimize our image quality in terms of 2D as well as in color, and even in Doppler, some of the basic measurements that we do for every single patient, and how now with our advanced AI tools, we can reduce intraoperative variability, we can reduce time, we can give our customer the best tools and for our patient the best care. So starting with the AI auto measure 2D, the AI spectrum recognition with the cardiac auto Doppler, what is the speckled tracking, what is the AI, and now the AI with the auto ejection fraction 3.0, the AFI and the importance of the AFI, the new AFI for the right ventricle, AFI for the LA, and the EchoPack. Starting with the raw data. As I mentioned, we cannot do anything if we don't have a raw data. That's why, as we can see here, we have like a different stage of processing. We have different box. First of all, we have the probe, and then the signal comes back from the probe and it goes through something called digital beamformer. And from the digital beamformer to the preprocessor, and from the preprocessor to the scan converter, and here it's the importance. So the function of the scan converter is to convert the raw data into video type signal that is sent to the graphic card and then to the display screen. So all the ultrasound machine, when they started the digital acquisition of the image, they started with a concept of acquiring this video type signal or the DICOM format signal. And that's why they are using in the past something that we call conventional of cine and video data. But this one here has a limitation to only process 25 frames per second. So having only 25 frames per second allows us only to do the adjustment for the brightness, for the contrast, 2D map, and the color map. But as we all know, we have so many settings that we can use to have an excellent image quality, and not only to adjust the image quality, but to do advanced quantification. So what we started to do with the GE is the original raw data is stored and it is processed as it is. And I mean by that, so during the acquisition, during the live scanning, if I have, let's say, 60 frames per second, I do image store, and even on the offline mode, I have an access to the original frame rate to the 60 frames per second. That's why now I'm able to adjust the 2D gain, compression, persistence of the DDP, reject, zoom, M-mode, Doppler gain, baseline, simultaneous, tissue priority, and even I'm able to do all the advanced 2D and even all the 4D navigation and the 4D quantification tools. So this is the power of the raw data. It's unique to us. It's unique to GE. And for that, with only one single image, we can derive our anatomical mode, this free position cursor line. We can place it on the left ventricle. We can do the ejection fraction, or even we can navigate it to the mitral valve to see if there is any prolapse, or even we can place it on the aorta and the left atrium to take the dimension. So from only single image, we can do so many measurements. This is the power of the raw data. This is the power of having an access to the original frame per second. Moving on to some of the settings that we can adjust to have a good image quality in terms of 2D, color, and Doppler. I'll be doing everything by sharing my echo pack, so it's be like more easy to understand what I'm mentioning. Just need the confirmation. Can everyone see my echo pack?
Oh.
Yes, we can.
Thank you.
Yes, I can see it.
Thank you. So starting with the 2D image. One of the first settings that I use to adjust my 2D image is the 2D gain. So let's see the difference. If I go up with the 2D gain, I can have a very bright image. And if I go down with the 2D gain, I can have a dark image. And having a darker image, I can lose a structure. So for example, here, I'm not even able to see the aortic cusps. Even if there is any vegetation or if there is any abnormality in the aorta, I'm not able to detect it. So I always recommend to be in the middle. So not so bright and not so dark. From the 2D gain, moving on to the frequency. So the frequency is related to the patient. And the frequency should be adjustable during the live scanning because as well, it's related to the probe. So if we have an obese patient and we need a better penetration, we should go down with the frequency. And if we have a thinner patient, we should go up with the frequency because no need for a higher penetration. After the frequency, we have different map for my 2D image. By default, the system provides us with the medium as map. But for sure, we have different color map. We have the vivid, light, bright, aqua, stamp, gold, and sepia. So it all depends on the physician, which one he likes to use. Usually, I will go with the vivid map. Why? Because I need to see better the endocardial border. I need to see better the valve. And especially if I'm doing a stress echo. So I need to detect the endo. I need to detect the epicardial border. The vivid map provides us like more clear image for both endo, epicardial border, and even the valve. Moving on to another settings, the compress or the compression. The compress is available on any system on the touch screen under the name of compress. And let's see the difference. Going up with the compression, I can have like a hazy image, a bit here on the left LA roof. And if I go down with the compress, I can have like a very bright image, even in the tissue and even on the epicardial border. So I need a clear image. I don't need to see like a noise inside the left ventricle. So I recommend with the compression to go between 55 to 57. So let's go a bit up. This is a 55 as compression. Now I'm able to detect excellent the endocardial border. I'm able to detect better the epicardial border, and now I have a good image quality. Moving on to another one, the DDP. We call it the data dependent processing, and the DDP provides us with all that we need to see inside my image. So if I need to see even the small details, the DDP allowed me to see all the details inside the image. Let's see the difference. Moving up with the DDP, also I can have like a bit hazy image on the LA roof, and going down with the DDP, I can have noise inside my image. So I recommend to go with the DDP around 2.3 to 3.6. So let's go up. This is a DDP 2.3. Now, excellent image quality, crispy valve, small visitation. I'm able to detect it even on the mitral valve or even on the aorta in this view. Moving on to the color. So let me go down to choose an image with the color. All right. This is an image while using the color Doppler. First of all, for the color, we need to make sure that the size of the box is inside my region of interest. This is one. Second, we need to make sure that the depth and the width of the sizing of the box is adequate to the region of interest. So here I'm looking at the right cavity. There is small tricuspid regurgitation. So no need to go very large with the sizing of the box. So we need to focus our color inside our region of interest. So here inside the right cavities. After the sizing of the box, we have the gain. Also for the color, we can adjust the gain for the color by using the rotary knob available on any keyboard and on the Vivid IQ on the touch screen under the name of active mode rotary knob. And going up with the gain, I can have very aliasing of the color, so many color inside my image. And going down with the gain provide me to lose my color. So I recommend to be in the middle with the active mode so I can see only the red and the blue without aliasing. After the gain, we have the variance. What is the variance? The variance basically is this green color here. And the variance highlights any turbulence jet. And I mean by that, if there is any regurgitation or if there is any stenosis, it will be highlighted with this green color here. So as we can see, we have a small tricuspid regurgitation. So only the regurg is highlighted with this green color. For sure, we can turn it off. So it depends on the customer if he likes to see it with this green color. So we can turn it off. And if we need it, we can turn it on. Sometimes we hear that the heart is bleeding. And I mean by that the color is not only available inside my region of interest, but it is going out from the cavities till the tissue. So to reduce this bleeding, especially if I'm looking to any ASD or VSD, so I need to have an adequate color map. So I need to go to the tissue priority and let's see the difference. Going up with the tissue priority allow me to lose my color, and going down with the tissue priority, I have now a very fast color. The color is moving from the cavities till outside till the tissue. So to reduce that, please make sure to go to the tissue priority and to put it between 8 to 9. Now I can see my color only inside my cavities. Moving on to the color map as well. So we have different one, the yellow cyan map E, yellow cyan mosaic map B, and red and blue map B. As well, it depends on the customer which one he likes to use. Usually, I recommend to go with the yellow cyan map B, so it's only related to this red and blue color. In addition, the scale is so important. So for an adult patient, the scale should be between 65 to 70. And if I'm looking or if I'm doing an echo for a pediatric patient, so we go a bit up with the scale around 80 to 83. And if there is any regurgitation, so we need to go down with the scale around 38. So I'm able to see the orifice regurgent jet of the regurg. But for a normal patient, 65 to 70 is fair enough. After the color, scale, gain, and everything, I'm gonna move to the Doppler. Usually we have like a very sensitive color Doppler, and there is no need to do like a very high adjustment. Only the one that are related to the baseline, going up, going down with the baseline. It depends on the structure. It depends on the valve that I'm doing the echo on it to see the tip of the gradient. And another thing, the scale, especially if I'm doing like aortic stenosis, I need to see the peak and the mean gradient. So I need to adjust my scale. in addition to the scale, we can adjust the gain for the Doppler by using the same rotary knob that I've used for the color flow. Active mode rotary knob on any system going up provide me with the bright image, and going down provide me with a darker signal. So in the middle and on a gray scale is good. So I'm able to see and I'm able to do any tracing to obtain or to have my peak and the mean gradient related to the valve. I need to highlight here that with our high-end systems, with the Lvot E95, with the Lvot E90, S60, S70, we're gonna see it later on with the other sessions, that we have something that we call the C-Sound. It's a software-based beamformer, provide us with a very high frame rate. And in addition, we can have an excellent image quality. And as we can see here, there is no more focal point. So there is a TCI, the true focal imaging. So there is no more focal point and allows me to obtain an excellent image quality, not even where the focal point is, but around all the sector from the near till the far field view of my image. Now moving on to some of the basic measurements. One of the most important measurements that we do for every single patient is the ejection fraction. And doing the ejection fraction, or I can do it with a different way. So even by using the anatomical mode, and as I see here, as we can see here, I'm able to do everything on the offline mode, from image optimization till now measurement. So starting with the anatomical mode. So acquiring a parasternal long axis view, storing it on the clipboard, on the system, or sending it to the echo pack, allow me to do it, or to do as well the ejection fraction by using the anatomical mode on the offline mode. So I only need to click mode, and the anatomical mode will be direct activated. I only need to click to drag it, to place it perpendicular to the left ventricle, and to do the ejection fraction by using the mode. But I need to highlight here that using the anatomical mode, as per the American and as per the European Society of Echocardiography, it is not validated. Why? Because we have a foreshortening. So I'm gonna go directly to the recommended one. So as per the recommendation, as per two articles, Roberto Long et al. And Mitchell et al., the only recommended view to do the ejection fraction is by using a parasternal long axis 2D and to take the dimension from the septum till the posterior wall in both diastole and systole. So I'm gonna do it manually, and we're gonna see together how with our new AI auto measure 2D, we can obtain the ejection fraction with less than few seconds. Let's start with the manual way. So this is the parasternal long axis view. EKG should be available across all my exam. So please, I recommend always to put the EKG. It is mandatory to put the EKG. I'm gonna stop my image. Sorry, I'm gonna go to the measure, and under dimension, I'm gonna start taking the measurement from the septum till the posterior wall in both diastole and systole. But before that, I'm gonna go frame by frame to the diastole. So let's go frame by frame to the diastole. Okay, and then I'm gonna go to the interventricular septum in diastole. And then the left ventricle in diastole, and then the posterior wall in diastole. I'm gonna do the same, but now I'm gonna go to the systole. So frame by frame to the systole. I'm gonna do the same. So interventricular septum in systole, left ventricle in systole, and the posterior wall in systole. And now I can have here my ejection fraction 60%. And if I put the height and the weight of the patient, we can get the mass index. But as we can see, everyone here, that doing this manual way, we have around 19 clicks to obtain the ejection fraction. This is one. Second, we have intraoperative variability. And I mean by that every physician, every sonographer can do this manual trace by his own view. And third, there is a time consuming. And fourth, there is not like accuracy. So we need to provide our customer the best quality of exam, and we need to provide our patients accuracy. That's why we are introducing this new AI Auto Measure 2D with only one single image as per the recommendation. So I'm gonna do everything as per the recommendation from one single image, parasternal long axis view. EKG should be available, so it's mandatory to put the EKG. And only by using a 3-click, we're gonna get the ejection fraction. Let's do it together. So first, I'm gonna stop my image. Second, I'm gonna press measure. And third, I'm gonna press auto. And that's it. The system do automatic trace for the left ventricle from the septum till the posterior wall in both diastole and systole, and provide me with the ejection fraction. And even I'm able to do the adjustment for any trace, since all those points are not linked together. So I can at any time, before storing my image, I'm gonna double click of any point here. I'm gonna do the adjustment for this one, for the left ventricle. I'm gonna place it here, let's say. I'm gonna go to the systole. I'm gonna do the same. I'm gonna adjust the posterior inferior wall, and that's it. So I can do everything before storing my image. I'm able to adjust the trace. And even if there is any LVH, if there is any septal bulge, the system can detect it, the system go up and do the trace. And once I will store it, I can have as well the mass index if I put the height and the weight of the patient. In addition, we can use it with irregular heartbeat, with atrial fibrillation patients, and it is validated, and there is a white paper. So from one single image, we can do like so many patients with less than 2 seconds, and we can have all the measurements that we want to have it, and it is related to the patient and as per the validation. Moving on to as well, that there is so many measurements also, like a Doppler measurement to be done for every single patient. So let's say if I have, or I need to see if there is any diastolic dysfunction, one of the measurements that I do is to place the PW Doppler on the level of the mitral valve, and I need to go to the measure, and then from the measure, I need to go to the mitral valve folder, and from the mitral valve folder, I need to go to the mitral valve E/A velocity, and I need to take the mitral valve E and then the A to obtain the mitral valve E/A ratio. So also, I have so many measurements to be done. I need to do like so many clicks from storing the image, then to go to the measure, and from the measure to go to the valve folder, and so on. Also, we need accuracy. Also, we need to reduce intraoperative variability, since everyone can do the trace for the E and for the A by his own view. We need to reduce the delay of the time to do like so many patients in less time. So that's why now we are introducing as well the new AI Auto Measure Spectrum Recognition. It is based artificial intelligence. And from so many clicks, I don't know how many clicks to be done, we only need to do 2 clicks. we freeze our image or we store it. So as we can see, I'm doing everything on the offline mode. So even we freeze it during the live scanning, or even we store it and we press only measure. And that's it. The system do an automatic tracing for the E over A and provide us with the mitral valve E over A ratio. How? From the simple volume, PW or CW, from the baseline and from my 2D image, the system can detect that I'm at the level of the mitral valve and do this automatic recognition for the spectrum. And we can at any time decline before storing the image. We can decline any from those traces. And once I will store it, we can obtain the average of all the signals inside my worksheet. Very easy, very rapid, less than 1 second, I'm able to have all the measurements that I need. And not only available with a 2D image, but even by using the TVI profile. So if I need to see if there is any elevated left ventricle and diastolic pressure, so also I need to put the TVI profile, I need to go to the measure, and from the measure, I need to go to the mitral valve folder, and from the mitral valve folder, I need to go to the E prime. It depends in which part the PW is available on the septum or even on the lateral. So I need to go to the E prime septal, and I need to mention the E prime septal. But as well, there is so many clicks to be done. Now, with the AI auto measure spectrum recognition, freeze only your image, store only your image, and press measure. And that's it. Due to the simple volume, due to the TVI profile, to the 4-chamber that is available here, and to the baseline, the system can detect that I'm at the level of the E prime septal and provide me with the E prime septal here. And we can at any time decline it as well. And once I will store it, this is my E over E prime septal. For sure, everything will be directly stored inside my worksheet. Even on the E prime lateral. So let's go to the E prime lateral now. I'm gonna only press measure, and that's it. This is my E prime lateral. This one, and once I will store it, this is my E over E prime lateral. So everything is here to reduce this intraoperative variability, to reduce the back pain that are related to the long time of procedure, and to provide us accuracy. And I need to mention here that even if we have irregular heartbeat, even if we have atrial fibrillation patient, we still can do this measurement. Also, one of the most important measurements to be done if we have aortic stenosis. So if we have this aortic calcification, we need to do the measurement for the aortic valve area. And to do it, we need to do like 3 steps. The aortic valve area is based continuity equation. And to do it, first of all, we need to have the Lvot diameter. And having the Lvot diameter, we need a parasternal long axis view. EKG should be available. So I'm gonna stop my image. I'm gonna go to the measure, and under dimension, I'm gonna go to the Lvot diameter. So measure here my Lvot diameter. Before that, I'm gonna go step by step to the mid-systole, and then I'm gonna take the Lvot diameter. After the Lvot diameter, we need to have the Lvot maximum and the minimum gradient. And as we all know, we need to have a 4-chamber view or 5-chamber view. The aorta should be very well seen to put the PW Doppler on the level of the Lvot. And now let's see how with the AI auto measure spectrum recognition with less than 1 second, automatic tracing will be done. So I'm gonna click measure, and that's it. Automatic trace for the spectrum from the aortic valve opening till the aortic valve closure. And this is my LVOT maximum and minimum gradient. We can decline any from those traces if I want, and I'm gonna store it. I'm gonna do the same. I'm gonna go to the second view to obtain my aortic valve area. So also 5-chamber view, CW on the level of the aortic valve. And I'm gonna click only measure, and that's it. In the past, I need to go to the measure, and from the measure to the aorta, and from the aorta to do it manually by doing the aortic valve tracing. I'm gonna decline, let's say this one. I'm gonna store it. And this is my aortic valve area by VTI and Vmax. Very fast way, very accurate way, less intraoperative variability. So the system can do trace for different spectrum and provide us with the average. Also, if I need to detect if there is any pulmonary hypertension. So since I have like a small tricuspid regurgitation, CW on the right cavities, I'm gonna click only measure, and that's it. The system can detect that I'm at the level of the tricuspid valve from the CW, from my 4-chamber view and from the baseline, and provide me with the tricuspid regurgitation maximum gradient. And once I will store it as well, I can have the average inside my worksheet. Moving on to one of the measurements as well, if I have the mitral stenosis. So if I have a mitral stenosis and I need to detect if there is any, or the mitral valve area. So basically we can do it by using 2 methods. So the first one is from a short axis view. I need to see the mitral valve in the middle. I need to see the interior and the posterior mitral valve. And I'm gonna use this view. I'm gonna remove the color. And to do the mitral valve area, so this is the mitral valve in the middle. This is my left ventricle. EKG is available. So I'm gonna stop my image. I'm gonna go to the measure. And under measure, I'm gonna go to the area. But before that, I'm gonna go to the mid-systole till the opening of the mitral valve. And then this is my mitral valve area by planimetry, and I will do the trace. As we can see, everything is done on the offline mode. So I'm doing everything on the offline mode due to our raw data. If we don't have a raw data, we are not able to do anything on the offline mode. And this is my mitral valve area by planimetry. Also, to do the mitral valve area, we have another way to do it. And one of the way I'm gonna go to the patient, and I'm gonna go to another patient just to show you how it can be done by placing the CW Doppler on the level of the mitral valve. Okay, I'm gonna go down to another exam. All right. So as I mentioned, even by doing the mitral valve area by planimetry from a short axis view, or even by doing by having the mitral valve peak and mean gradient. So having a severe mitral stenosis, so we need to do the assessment of the peak and the mean velocity. So for that reason, first of all, we need to place the CW Doppler on the level of the mitral valve. One second. Okay. We need to put the CW here on the level of the mitral valve. I'm gonna do a bit adjustment here, and then we're gonna go to the measure, and under measure, I'm gonna go to the mitral valve here, and I need to go to the mitral valve trace, and I need to do the trace of the mitral valve gradient. And now I can have the mitral valve maximum and the minimum gradient. In addition, we can use the pressure half time. So also we need to go to the mitral valve, and from the mitral valve, I'm gonna go to the pressure half time. And we need to take the mitral valve by PhD, so we can get as well the mitral valve area by PhD. So this is two ways to have, or by using the maximum and the minimum gradient, by using the pressure half time, and also by using the aortic valve or the mitral valve area by planimetry. Also, one of the most important measurement, as I mentioned before, is to do the ejection fraction, and there is so many ways. So another way to do it is by using the Simpson method. And using the Simpson method, we need to have two views. So 4-chamber and 2-chamber view. This is as per the recommendation. So we need to do it by using two views, 4-chamber and 2-chamber view. I've already stored a 4-chamber. I have already stored a 2-chamber view. I'm gonna go to the measure. EKG should be placed. I'm gonna go to the measure, and under volume, I'm gonna go to the biplane, and from the biplane, I'm gonna start doing the manual trace for the endocardial border in both diastole and systole. But before that, I'm gonna stop my image as well. I'm gonna go to the end diastole. So I'm gonna go to the end diastole frame by frame. And I'm gonna start doing the manual trace from the tip of the anterior mitral valve till the tip of the posterior mitral valve. And then set and set. I'm gonna go frame by frame to the end systole. So this is my end systole here. I'm gonna do the same. And then set and set. And this is my ejection fraction by using the 4-chamber view. I'm gonna go to the 2-chamber view now. I will be following the same steps. So end diastole and then end systole. I'm gonna stop my image, go to the measure, and under biplane, I'm gonna go to the left ventricle end diastolic in 2-chamber. So let's go to the end diastole. manual trace. So I'm doing the manual trace. Everyone can do this manual trace by his own view. So first, we have intraoperative variability. I'm going to go to the NC stall now. And now set and set. This is my ejection fraction in two-chamber view, and this is the biplane ejection fraction. By here, as I mentioned, I'm doing everything manually. So that's why also we need to provide the customer a quick tool to provide me with the ejection fraction, to provide me with the stroke volume, to provide me with the length. I need everything with a quick tool. We are introducing the new AI auto ejection fraction. How it can be done? First of all, it is based artificial intelligence. We only need to acquire a 4-chamber view to have a 2-chamber view as well. We need to put the EKG, so it's EKG mandatory, and we need to have a frame rate between 38 to 80 frames per second. And we recommend as much as we can have a higher frame rate, as much it is better. So the system or the algorithm can track easily the endocardial border and do this automatic trace for the endocardial border. But before that, I'm gonna reshare the presentation, and I'm gonna talk a bit about what is the basic of the ejection fraction, and later on about the AFI. So all of them are based on Speckled Tracking. I'm gonna reshare the presentation. Can everyone see the presentation?
Yes, it's visible.
Thank you. So first of all, the Speckled Tracking, or the speckles, are basically a number of pixels with a specific shape, and it can be detected by the algorithm as a speckle. So here we have a speckle. In this frame, we have a speckle. And on another frame, we have another speckle. And moving on a third frame, we have another speckle, and so on. So the algorithm can track those speckles frame by frame, and now we can obtain the time, we can obtain the distance, and the velocity. So this is how the auto ejection fraction works. It is based on Speckled Tracking. Let's go back to the EchoPack. As I mentioned, we need a 4-chamber view. We need a 2-chamber view as well. EKG is here, frame per second 48. I'm gonna go to the measure, and under measure, I'm gonna click auto ejection fraction. And let's see how now with the new AI auto ejection fraction, the system can detect directly the second view, the 2-chamber view here, and highlighted with this blue box. Due to the view recognition, the system can detect directly. This is a 4-chamber view, do an automatic tracing of the endocardial border, and we can at any time stop the image, we can adjust the speed, we can as well zoom it, and even we can adjust the gain, everything on the offline mode. And the system can do the automatic processing. This is an automatic processing also, and provide me with the ejection fraction for the 4-chamber view. So this is my ejection fraction. This is the volume in NC stall and diastole, stroke volume, length in systole, length in diastole, heart rate, and the cardiac output. And even we have the ability to do it manually. So if I go and I reprocess, the physician have the ability to do it by using the 3-click. So I'm gonna go to the 3-click, and I'm gonna look at the upper right corner pectogram, and I'm gonna follow the 3 points. This is the lateral, this is the septal. So septal base, lateral base, and the apex. Automatic tracing. I'm able at any time to click and drag any dot here to do the adjustment for the trace. And once I click a process, also I can have my ejection fraction. Even we are able to do the adjustment for the volume in end diastole and the volume in end systole. We only need to click and drag any dot and to do this adjustment. At any time, we can do everything, even on the offline mode, even here on end diastole. Let's see how, once I click approve and select next, due to the view recognition, the system will provide me directly with the second view, the two-chamber view. So approve and select next. Automatic tracing, I'll be doing a bit adjustment for the interior wall and then process. Now, this is my ejection fraction in two-chamber view. And this is the biplane ejection fraction. So on the average between the 4 and the 2-chamber view, we can adjust the volume as well in end systole here a bit if I need to do it. Even I'm able to adjust the volume in end diastole. Everything is here, one single tool, very rapid, very easy to be done. Only I need to acquire to store the views, to put the EKG, and it is validated, and there is a white paper. And not only now, we have this view recognition and the artificial intelligence, but even now with the new AI auto ejection refraction, also we are supporting DICOM images. So especially for patients receiving Herceptin, we need to do the follow-up by using the auto ejection refraction, and later on we're gonna see the AFI. We need to standardize the value. So we need to do everything by using our tool. Now we can derive the auto ejection fraction images for end to chamber view. We can derive the images from a third-party ultrasound scanner to our system, to our GE system, and to do them on our tool by using our auto ejection fraction, even on the system or even on the EchoPack. Moving on to also one of the most important measurements is to detect or to have full information about the volume of the left atrium. So as we can see, everything is done on the offline mode. To do the LA volume, 4 chambers should be stored, 2 chambers should be stored. But my region of interest here is the left atrium. So we need to see the left atrium very well, especially for the LA roof, to do this trace. So I'm gonna choose this one here, since the LA roof is very well seen, and I'm gonna go down and I'm gonna choose this one to do the trace on 2-chamber view. So let's start with the 4-chamber. As I mentioned, EKG should be available. I'm gonna stop my image, go to the measure, and under volume, LA volume. For sure, we need to activate all the measurements. So if there is anything like missing for the measurement in the measurement folder, we can add them. So even if there is something missing, we are able to add any measurement on my measurement box. This is the left atrium and diastolic volume and 4-chamber view. So let me go step by step to the end diastole. And I'm gonna take the trace. Then set and set. I'm gonna do the same. I'm gonna go to the end systole. From the tip of the mitral valve till the tip of the mitral valve, from the tip of the anterior to the tip of the posterior mitral valve. And then set and set. So everything is here. I can have the LA in end systolic volume, even I can have the length in diastole. I can have the average for both end diastole and systole. I'm gonna do the same for the two-chamber view, EKG available, stop, go to the measure, and under LA volume, I'm gonna go to the left atrium and diastolic in two-chamber view. So let's go to the end diastole. From the tip till the tip. And now set and set. Moving on to the anti-stall. As well, from the tip till the tip of the mitral valve. And then set and set. So now, this is the average here related to the mass index. Also, this is the two-chamber. This is the average here. This is the anterolateral, and everything will be available inside my worksheet. We can at any time go to the worksheet and delete any measurement if I don't need it or if I need to adjust anything. Moving on to the AFI. What is the AFI and what is the importance and the definition of the AFI? So doing the ejection refraction. So the ejection refraction basically provides us with the percentage of the blood that is ejected by the heart in every single beat during systole. So we can only obtain a global idea about the percentage of the functioning of the heart. But what is happening inside the myocyte level, we are not able to detect it or to assess it. That's why the AFI now becomes mandatory. The definition of the AFI, or the automated function imaging, is to provide us to see if there is any wall motion abnormalities by tracking of the percentage of the lengthening and the shortening of the left ventricle during systole. And at the end, we can get the bullseye, that is the global strain with the segmental strain from the apex till the mid, till the basal part of the left ventricle. From clinical part, why it is so important. So if we have ejection fraction with preserved or left ventricle hypertrophy with preserved ejection fraction, if we have any systemic disease or systemic neuro disorders, cardiotoxicity coming from Herceptin products, so we need to assess, we need to see what's happening inside the myocyte level. So also it's based on Speckled Tracking, like the auto ejection fraction. But here, to do it, we need to have three views. So we need to have apical long axis, 4-chamber view, and 2-chamber view. EKG mandatory. Frame rate should be between 38 to 80 frames per second, but we recommend as much as we can have a higher frame rate between 60 to 66, it is better. So the algorithm can track easily the endo and the epicardial border. In the previous release for the AFI, the only recommended view to start with was the apical long axis. So it was mandatory to start with the apical long axis. And the three views should be acquired with same heart rate and same frame rate. And it's a bit difficult for the physician, for the technician, to have three views with similar heart rate and similar frame rate. That's why we need to help them. We need to provide them not with the accurate tool, but even with a helpful tool. So I'm gonna store, I've already stored so many views. I've stored different 4-chamber, different apical long axis, and different 2-chamber view. I'm gonna start with this view, with the 4-chamber view. So I'm not gonna start with the apical long axis to show you how this tool now based view recognition and based artificial intelligence. So I'm gonna go to the measure, and under measure, I'm gonna click AFI. Let's see how the system can detect directly which apical long axis and apical 2-chamber has similar heart rate and similar frame rate like the one that I start with, and do automatic highlighting for the two views. And automatic view recognition for the fourth chamber. I didn't mention that this is a fourth chamber, and automatic trace for the endo and automatic trace for the epicardial border. And we can at any time click and drag any dot for the endocardial border, any dot for the epicardial border, and it is unique to us. It's unique to GE. Even if the epicardial border is outside the sector, we are able to click, to drag it, and to make the value accurate, to make our bullseye accurate. In addition, automatic processing will be done to provide us the global strain, the strain curve with the aortic valve closure, the curved anatomical mode, and the segmental strain, segment by segment for the lateral and for the septal part. And if I need to do it manually, so if I need to use the 3-click, I'm able to do it. So I go here, I'm gonna mention the 3-click, and let's see how. I'm gonna follow the upper right corner pictogram. This is the lateral, this is the septal, everything is mentioned by the system. So this is the septal base here, this is the lateral base here, and this is the apex. Automatic tracing as well for the endocardial border, for the epicardial border. We can also click and drag, do the adjustment of everything, even for the epi here. So I'm able to adjust it and then process. So even it can be done by the system or by using the 3 clicks. This is the global strain as well, strain curve, curve anatomical mode, and the segmental strain for the lateral and for the septal. And not only we can obtain the global strain, but even with this new AI, auto ejection AFI 3.0, with the view recognition and DICOM support, we can obtain our ejection fraction from the AFI itself. So we only need to go here, and since it's a 4-chamber view as per the recommendation, ejection fraction should be done with a 4-chamber. So that's why it is highlighted. So ejection fraction, this is my ejection fraction. I can click, do a bit adjustment for the volume and diastole if I need, and for the volume and systole as well. Everything is here, volume and systole and diastole, stroke volume, ejection fraction, length, in systole, diastole, heart rate, and the cardiac output. We can have so many layout also. So this is the quad, and this is the single. My yo-yo image, even I can change the color. And let's see how, once I click approve and select next, I'm not gonna go to the clipboard. I'm not gonna do everything, anything. I just gonna click approve and select next. Apical long axis, view recognition, automatic tracing endo, epicardial border. We can click and drag, do the adjustment for everything here. We can do it by using the 3-click, and now process. This is the global strain also for the apical long axis with the strain curve, curved anatomical mode, and the segmental strain for the anterior septal and for the posterior wall. And since it's an apical long axis, so that's why the ejection fraction, it is not highlighted. Now, approve, select next. Automatic trace endo, epicardial border. I'm gonna do a bit adjustment by using the region of interest width here. Even we can adjust the yo-yo width, and now process. Same, global strain. This is my strain curve, curved anatomical mode, and segmental strain for the anterior and for the inferior wall, segment by segment, from the septal till the mid till the base. And now it's a 2-chamber, ejection fraction is here. So I'm gonna click ejection fraction. This is my ejection fraction. Also, we can do a bit adjustment if I need for the volume and end-systole. And now this is the biplane ejection fraction. So not only every ejection fraction for every single view alone, but even the average between the 4 and the 2-chamber view, the average of the stroke volume, the average of the cardiac output for the volume and end systole and the volume and diastole. And this is my bullseye. So the bullseye is the global strain with the segmental strain, segment by segment, from the apex till the mid till the basal part of the left ventricle, with the strain information here in 4-chamber, in 2-chamber, apical long axis. This is the average, the PSD, the aortic valve closure, and the heart rate in the apical long axis. I made sure here to have like a bit abnormality just to highlight the difference. So the cutoff of the bullseye is from -20 till 20. So everything is in negative is normal, and then if we go up till positive, so we have here the light pink, and then light blue, and then the dark blue. So normal, hypokinesia, akinesia, and dyskinetic. So this map, the peak systolic strain red and blue, is related to provide us an information to detect if there is any wall motion abnormality. So we can tell in which part of the left ventricle, in which segment we have abnormality. Not only like a global strain. In addition to this map, we have another map, the bullseye, with the 3 traces in 2-chamber, 4-chamber, and apical long axis. And we have the bullseye with the review with the 3 views. I'm gonna go back to the bullseye only. In addition to the peak systolic strain red and blue, this map here, we have another map. We call it peak systolic strain green, yellow, red. As we can see, all the numbers are similar between the green, yellow, red, and the red and blue. So there is no difference in number, but here the difference is only related to the map. It depends on the customer which one he likes to use, but both of them provide us to see if there is any wall motion abnormality. In addition to the peak systolic strain, we have a new map, the PSI, the post-systolic index, to see what's happening in post-systole. And also we have the TTP, or the time to peak, and we call it as well the peak strain dysplasia. And this map here is so important, and it is related to detect if there is any desynchrony. And I mean by that, if there is any delay for any from those segments, if I go back to the bullseye with the trace with this map, to detect if there is any delay of those segments to attend the peak strain at the same time. So we have desynchrony. And we've been using this map especially for pacemakers. So if we need to put a pacemaker for the patient. The AFI with the view recognition is one of the most important tool, especially for patient receiving Herceptin. Why? Because this product affects the heart muscle. So if we only do ejection fraction, we cannot tell what's happening inside the myocyte level. So I'll be sharing a study done at the Indian Academy of Echocardiography on a patient receiving Herceptin. We've did auto ejection fraction, and we've did the AFI. As we can see here on the baseline, the ejection fraction was 54%, and the global strain -11, so normal. After 3 months of receiving Herceptin, the ejection fraction is 53, so it's almost normal, but the global strain dropped down to -11. And after 5 months of receiving Herceptin, the ejection fraction is 29%, and the global strain is -7. So as conclusion, if we only do the ejection fraction for those patients, after 3 months, we can tell, okay, there is nothing in the heart, but no, there is something bad happening in the heart and we need to assess it. That's why the AFI becomes mandatory for those patients. And 65 to 70% from the literature in the market are done by using our AFI and auto ejection fraction and our tool. And now as well, with the AFI 3.0, we are supporting as well DICOM images. So we have the ability to derive our AFI images from a third-party ultrasound scanner to our GE EchoPack, to our GE system, and to do the AFI on our tool by using our tool to standardize the value and to provide the customer what he deserves from patient care and good routine between every single session. In the past, all the studies has been done on the left ventricle. So the right ventricle was like a forgotten chamber, everything on the left ventricle. But now during COVID, we are facing lot of problems related to pulmonary embolism. So it is mandatory to assess the right ventricle systolic function. That's why GE are introducing the AFI for the right ventricle, and it is EKG mandatory. So we need to put the EKG, and the frame rate is should be between 38 to 80 frames per second. As much as we can have a higher frame rate, as much as it is better. So 60, 67, 70, it is excellent for a frame per second. And we need to have one single view for chamber view, but our focus image should be the right ventricle. So we need to see the right ventricle free wall and the right ventricle septal wall with the apical part. It is based on Speckled Tracking, like the AFI and like the auto ejection fraction. I'm gonna stop my image. I'm gonna go to the measure, and under measure, I'm gonna click AFI right ventricle. Now, automatic processing will be done. We are able to stop the image. We are able to adjust the frame, to zoom it as well, and even to adjust the gain. Even we can change the cycle. So we can choose even cycle number 1, number 2, it depends. And now we need to follow the upper right corner pictogram. So this is the right ventricle septal here, and this is the free wall. Everything is mentioned by the algorithm. So right ventricle free wall base, right ventricle septal base, and this is the apex. Automatic processing as well. We can click and drag, do the adjustment for any dot here, and even we can adjust the epicardial border. It is unique to us also. At any time, we can adjust everything. We can use the region of interest width here, and now process. Let's see how one single image we can have our global strain for the right ventricle, our free wall strain, and our TAPSI. And it is unique as well as measurement for us. And not only the free wall strain, the septal strain, segment by segment, also it is unique to us. So global strain and even segmental strain for the free wall and for the septal wall, with the strain curve and the curved anatomical mode. We can have another layout, the single layout, and we can change the color. Very easy tool, very rapid to be done, accurate, and validated with a white paper that we can share it later on with you. In addition to the AFI for the right ventricle, also the left atrium in the past was as well like a forgotten chamber. No one has done any study on the left atrium, but if we have a patient with atrial fibrillation or irregular heartbeat or severe mitral regurgitation or myocardial infarction, sometimes the problem is related to the left atrium. So we need to assess the left atrium function. We need to see the strain, the value strain of the left atrium, and not only the value strain, we're gonna see now how we can obtain from one single tool with only 2 views as well the ejection fraction. But we need to put the EKG. The frame rate should be between 38 to 80 frames per second. As I mentioned, as much as we have a higher frame rate, it's better. Our focal image should be the left atrium, and we need to acquire a second view, the 2-chamber view, as per the recommendation. I'm gonna start with the 4-chamber view. I'm gonna stop my image. I'm gonna go to the measure, and under measure, I'm gonna click AFI for the left atrium. Automatic processing will be done. We can at any time, like the AFI for the right ventricle, stop the image, speed it, zoom it. I'm gonna go down a little bit with the zoom. We can adjust a bit the gain. As well, we can choose the cycle, even cycle number 1, cycle number 2, and we can flip the image. So if the physician likes to see the left atrium at the left side, we can flip the image as well. Now we need to select the view. So I'm gonna go here. This is the 4-chamber. We follow the upper right corner pictogram, and let's follow the 3 points. So this is the septal base, this is the lateral base, and this is the LA roof. Automatic tracing, also I can adjust epicardial border, and endocardial border. We can use the region of interest as well. And now process. And let's see how the system provides us with all what we need from the strain reservoir, the quantity of the blood inside the left atrium when the left atrium is filled with blood, the strain conduit, the strain contraction, and the LA volume maximum. If I need to see every single strain on the map, we can click on it. So this is the strain reservoir. It will be highlighted here. This is the conduit, this is the contraction, and this is the volume maximum. And not only the strain R wave, but even the strain P wave. And everything will be highlighted as well on the strain P wave, from reservoir till conduit, till contraction, till volume maximum. Not only strain, but even ejection fraction. So I'm gonna click ejection fraction, and this is my ejection fraction for the left atrium in 4-chamber view. Ejection fraction with all the measurement that I need. Even we can adjust the volume maximum, and we can adjust the volume minimum. With less than, let's say, 2 seconds, I can have everything. I can adjust everything, and I can approve it. I can store it inside my worksheet. Even later on, I can have an access to all the measurements and to all the views that I need. Even the frame, I'm able to do it from here. So the volume maximum frame, we can adjust it from here, and even the volume minimum frame could be adjustable as well from here. Now I'm gonna approve and select next. We need to mention the second view, the 2 chambers. So here there is no view recognition. So I'm gonna go here. I'm gonna choose this view since the LA roof is very well seen. I'm gonna adjust a bit the gain. We can run the image as I mentioned. We can choose the cycle. We can flip it. Even if I flip my image, the tool works with an accurate value. So even if I flip it, I still have accuracy. And now to chamber view, follow the upper right corner pectogram, infero base, antero base, and LA roof, automatic tracing. Sorry. All right, I'm gonna do a bit adjustment for here. So as we can see, the epi is outside the sector. So we can click, we can drag it to make everything in a good way. And now process. Same information. We have, this is the two chamber here. This is the strain R wave. This is the strain P wave as well. This is the strain reservoir for the two chamber. Everything is mentioned here as well. This is the conduit, this is the contraction, and this is the volume maximum with the average between the 4 and the two chamber view. So even we can get, also we can get the biplane strain reservoir, biplane strain conduit, contraction, and the volume maximum. The average between the 4 and the two chamber view. And this is my ejection fraction. With the biplane ejection fraction for the 4 and the two chamber view, with the average of everything for the volume maximum, minimum, the pre-A, and we can adjust the volume maximum from here. We can adjust the volume minimum from here. So our aim is to provide our customer the best tool, accurate tool, and validated tool. So as well, our AFI for the left atrium is validated, and there is a white paper. I'm gonna reshare the presentation. Recapitulation about what we had and now what we have with the ultra addition release. So the curved anatomical mode in terms of navigation tools, the LVO contrast, the smart stress, the blood flow imaging, and now with the ultra addition release, the scan coach. In terms of flow quantification, the cardiac autodoppler that is based artificial intelligence. Now with the ultra addition release, the AI auto measure spectrum recognition with artificial intelligence. The difference with the cardiac autodoppler is with the cardiac autodoppler, we need to go to the valve folder and then we press auto. But as I mentioned previously, with the spectrum recognition, no need to go to the valve folder. We only need to press measure to save, to store our image, and to press measure. In terms of valve and chamber quantification, the Z-score for pediatric, and now with the ultra addition release, the AI auto measure 2D based artificial intelligence, auto ejection refraction based artificial intelligence, and AFI with the ultra addition, the new AFI with the view recognition based AI tool, and DICOM support. Moving on to also another tool that is very helpful to allow us to detect the function of the heart is the LVO contrast. So we give a contrast for the patient and provide us with an excellent understanding for the myocardial tissue, how the myocardial tissue is moving. Also the smartest stress, and we call it smartest stress. Why? Because the system do an automatic adjustment for all the settings that has been done on the baseline. So let's say if I have the baseline and then a peak and then recovery. So all the adjustment for the settings or all the settings that has been done on the baseline, like compression, DDP, everything that has been done on the baseline, directly the system doing it for the peak and for the recovery. And not only that, but even the system shows us at the side the images that has been acquired on the baseline to lead us through the second view on the peak, on the recovery, and to do a good comparison between all the levels. That's why we call it smart stress. Also, in terms of shared services, so there is no limitation while using our GE system. Even in terms of shared services, we have a solution, the logic view, to increase the field of view. So now we are able to detect large organ on one single image that cannot be seen on one single image. So we can detect like a large organs. Also, the blood flow imaging to see the dynamic flow of the blood inside the vessels, and the pediatric. So we never forget our pediatric patients. Also, we need to provide them the best patient care. We need to provide them all what we have for adults. So even in terms of probe, the 6S for pediatric, the 12S for neonate, the 90RS probe as a 2D transesophageal. All the images are raw data images. We can use the anatomical mode as well. We can adjust all our image quality or the settings on the offline mode, and we can use all our advanced AI tools from cardiac auto-Doppler till auto ejection fraction 3.0, AFI 3.0, AFI for the right ventricle, left atrium, and the virtual apex. So it's a button on the touch screen to obtain a wider sector here, so we can see all the structure at the side of the sector and the Z-score as per the publications. In addition to all what we have as tool, we need to give educational tool. We need to provide the customer, and especially our new physician and the technicians, tool that help us, or that help them to acquire the view. So the scan coach. The scan coach it's an educational tool. Provide us with an information how to put the probe and how to do the orientation of the probe. And in addition, provide us with an anatomical reference to see how the scan plan is located inside the heart. So it becomes easier for the physician or for the technician to acquire the view. And not only related to the view, but also related to the Doppler. So it supports Doppler on the mitral valve, tricuspid valve, and the aortic valve as well. This is a quick a slide for the cardiac auto-Doppler based artificial intelligence. So we have 93% less clicks, lower intraoperative variability, acceleration of the workflow. But as I mentioned, we need to go to the valve folder by using the cardiac auto-Doppler. The AI auto measure 2D for the ejection fraction. Now we have 99% accuracy, 100% reproducibility, and 84% less click. So from 19 clicks, we only need to do 3 clicks, freeze, measure, and auto, and everything will be done automatically. The AI auto measure spectrum recognition, also very important tool in terms of Doppler. In any valve, available on any valve with irregular heartbeat, AFib patients, we can have 98% accuracy, 100% reproducibility, less intraoperative variability, and time consuming. The AFI 3.0 that is based view recognition and ICOM support, as I mentioned, we can derive all the images for the AFI and the auto ejection fraction from third-party ultrasound scanner to our system and standardize the value, the AFI for the right ventricle. I made sure to do everything on the echo pack, so it becomes more easy to understand how the tool works. So we can obtain everything in terms of global strain, free wall, septal wall, and even the TAPSI. And the AFI for the left atrium as well. It's a GE healthcare tool, very accurate, very user-friendly, easy to do navigation, and very fast to obtain all what we need, such as left atrium strain, LA volume, entity fraction results, and everything in terms of 4 and 2 chamber view. And in addition, support images from previous data release. At the end, I need to highlight the importance of the EchoPack, the system that I'm using right now. So as we can see, everything is doing on the offline mode. We can do everything that we call post-processing. We can do storing. We can do all the advanced 2D AI tool, and even 4D navigation, even for the quantification, for the valve quantification, chamber quantification in adults, in pediatric, in vascular. So even a stress echo, even if I do stress echo, I need to do analyze, I'm able to do it. And not only that, we can customize our report. So even for every single physician, I'm able to customize the report. Every sonographer can have his own report by his own template and order from the measurement till the findings, till the conclusion and images. I'm gonna just reshare the EchoPack to go quickly through the EchoPack. So as we can see, we only need to go here to the report and to click findings. We have so many templates. So even we can have, it's a factory template. We can have so many factory templates already done, but we can customize as well the template. And we click findings. Let's see how. From the EchoPack, we have the cardiac adult, we have the vascular, we have the stress echo as well as report. We can mention the rhythm. We can tell how was the study, the quality of the study, the chambers, starting from the left ventricle as a global left ventricle. And even if there is any regional segment abnormalities, every single segment alone, the right ventricle, the left atrium, the right atrium. If there is anything missing, we can add statement. So we can also add anything. We can press OK, and we can have it inside my conclusion. If I did any contrast as well, if there is any ASD or VSD, the valve in terms of aorta, mitral, tricuspid, pulmonary valve, everything is available. If there is any mass or thrombus, the vessels dilatation and the ascending, descending, inferior vena cava, pulmonary valve, pericardium, if there is any pericardial effusion, if there is any tamponade, and even we can do comparison between the previous study and the new one by using even previous study, there is a change or no change. Even here for the stress echo, we can tell how was the heart rate by bicycle, treadmill, why I've stopped the exam, the reason, it was a good exam or fair exam, how was the EKG, and the rest, how was the EKG during the exercise, the blood pressure and the heart rate, how was the echo at the baseline. If I did dobutamine, there is a different stage of a dose from low to mid to peak. Even the exercise echo, how was it? And we can mention the conclusion. One more thing, even if we don't have the EchoPack, we have EchoPack built in every single system. So even on any system from the T series till the high-end system till the E95, we have the EchoPack built inside the system. We can navigate all the images. We can do everything on the offline mode and post-processing, and even we can go to the report and we can go to our findings and do our report. Thank you so much. Can everyone still hear me?
Yes, we can, of course. Thank you very much, Joelle, for a wonderful session.
Thank you,
I'm
Joseph.
just waiting to see if there are any questions. We've sent out a request. If there are any questions, you can please post them on chat. So we're just waiting to see if there's any questions or feedback. But again, thank you very much for illustrating in detail all these new and advanced tools and some of the basic tools that have now become more automated and using, of course, AI, which has been really a breakthrough in bringing us simpler and easier and faster and more reproducible ways of doing the things we do routinely. So again, thank you very much, Joel, for this session. Are there any questions or comments? I don't see any questions or comments. So I take it that the message was clear and vivid. So appreciate everyone staying with us at this long time. Yes, Sophie?
Jodette, sorry, I see that I have an Ali with his hand up. Oh, no, it's gone.
Oh, okay.
Okay.
Maybe they might have dropped the call trying to raise their hand, or maybe they were trying to end the session. Okay.
Just give it another minute, if that's okay,
sure.
just for questions.
Sure. Sure.
I see there is a question.
Yes, there's a question. Any use for intervention for valve and valve? Actually, we haven't spoke about 4D visualization or navigation yet, but we have lots of visualization tools, of course, in terms of 4D. So we'll talk about those starting next week. Next week we have the ACE 4D Echo navigators, and the very last session we'll have an in-depth of the tools and means of visualization and navigation for structural heart procedures. So we will get to that. Would you please better explain how speckled tracking technology provide auto EF? Yes, well, speckled tracking helps define and track the endocardial border, which is tracked per the guiding points. If you remember when Joel was drawing the region of interest, what we call ROI, and that's the area where we are telling the algorithm to search for the speckles of the endocardium. And once it tracks that endocardium, then it tracks the endocardium from diastole to systole, and of course the area in diastole, area in systole, and it uses the simple Simpson biplane calculations, discs calculation for the measurement of the volume in diastole and systole, and hence the ejection fraction. But mainly, instead of us having to draw the region of interest or the area in diastole and systole manually, speckled tracking does the job for us. So that's mainly how speckled tracking works for AutoEF. Echo-wise, I think this is a continuation or a continuation of the previous question about valve and valve. Yes, we'll talk about 4D navigation, cropping and navigation. Is there literature from GE concerning the step-by-step usage of EchoPack? Yes, there is, of course, the manual, and we have also quick guides, and we also have some PDFs and even some videos showing you how to do all these advanced tools one by one. If you go to the Vivid Club, you'll find lots of videos and lots of literature. Any other suggestions, Joel?
Yeah, for Vivid Club, it's very easy to reach it, and there is so many videos, easy to go through them, to show them like step by step how it can be done.
Great. Okay, I'm confused with automated measurement of ENA waves in your presentation. The system measure wave in late diastole and considered E wave. Can you clear, please? Can you show it again, Joel, if you still have your EchoPack working?
Yeah, let me reshare my EchoPack.
Yeah.
Okay. Can you see it?
Yes, we can. I think it's pretty straightforward when you have a mitral valve flow.
Yeah. This one.
Yes.
Okay, so I only press measure by using the spectrum recognition.
Yeah. Well, it's the E is in early diastole, and the A is the next one. But it appears as if the A is with the QRS. It's just
With QRS.
The waveform is I mean, it's basically it's a long diastole for this patient, so they look paired as if the A is before the A, but this is a normal
Yes, and the
EA
QRS,
waveform. Yeah. So the E is normal, early diastole. The A is the E with the slope for the pressure half time, and the A afterwards. So
yeah.
Great. Thank you very much again. If there are no further questions, we are happy to close at this note. And again, a reminder: we have the next sessions will be again on weekly basis. So we'll see you hopefully next week with the next advanced course in echo, the next ACE, which is going to be for the echo navigators. And we will go on the basic principles of acquisition, cropping, navigation for 4D, and we'll go to more advanced for the quantification tools on the following weeks as well, and as per the calendar which is in the landing page and the registration page that you have all visited. So again, thank you very much. It is really a pleasure having everyone here with us, and we are looking forward for the future sessions. Thank you, Joel, for a great session. And again, thanks, Sophie, for all the efforts in the background. Thanks, Dr. Elijah. I think he left us. He's in meetings. I know he's in Geneva for some meetings, as well as George from PASCAR. We again thank PASCAR for hosting us and enabling us to do these sessions under the umbrella of PASCAR and their respective members, cardiologists, surgeons, and sonographers. So again, thank you very much. And with this, I think we close this session. Thanks, Sophie. You can close the session now.
Thank you, Rhoda. Thank you, everyone.
Thank you. Have a good evening.
Thanks.
Thank you. Thank you. Bye.
Thank you. Bye-bye.